Welcome again to today's HPI webinar, focusing on dentists who participate in Medicaid, who they are, where they locate, how they practice. For those of you that may not be familiar with us, the Health Policy Institute is a research think tank within the ADA. We focus on scholarly research on various aspects of the dental care sector, really focusing on health policy or health services type research. Thankfully, the work is getting lots of traction. We are not ivory towers, so to speak. It's really great that the team's work is finding its way into policy circles at both the state and federal level, news stories, and even in the private sector industry. Why are we gathered here today? So we are launching, we have recently launched a new paper that's been published in the journal Medical Care Research and Review, led by our health economist on staff, Kamyar Nassh, where we have some really interesting new novel research related to dentists in Medicaid. I want to give you some background on kind of why we did this. And then I'm going to turn it over to Kamyar, and you'll see in a sec I'm going to introduce our panel who's going to join us for a discussion. In terms of just tying up housekeeping, as usual, this webinar will be recorded. Slides will be available. You'll get that by email in the next couple of days if you registered for this webinar. Throughout this webinar, please use the Q&A box located on your screen to submit any questions. We have Adriana Menezes in the background and Silvia Zeno helping out with that. So keep the questions coming anytime throughout the webinar. We'll have lots of time for Q&A. Use the chat function if you have any audio, visual, technical questions. And let's keep going. So many of you are familiar with this type of publication that we've been doing for years. One of the things we've been trying to track is how many dentists participate in Medicaid. This is kind of our classic approach that we did for several years, where we counted dentists who enrolled as participating providers in Medicaid or CHIP. And these data were sourced from InsureKids Now. Every state submits these data. It's pretty accurate in the vast majority of states, but it measures one thing. It measures whether a dentist has enrolled to be a participating provider, nothing else. I've had many conversations with many public health people. We're extremely transparent about what we measured and what we didn't, but this is all that we could find for many, many years that we could report at the state level. Is it perfect? No, but the whole point of health policy research is start with what you have, keep iterating, keep improving, get people talking, get the data improved, and move on. But still, interestingly, lots of insights from this type of research. Our stat was that 43% of US dentists had enrolled to be Medicaid or CHIP providers. There's differences by gender, there's differences by race, there's huge differences by practice type, in this case, DSO, dental service or dental support organization. Much more likely that dentists in those types of models participated in Medicaid versus private practice dentists in smaller practices. We also then moved into our next iteration of research as better data became available. So we worked to obtain claims data from all states via the TMSIS program. And not to bore you, but we had a webinar on this publication last year where it went to the next step, where we're able to actually measure patient volume. So instead of which providers have enrolled, we can actually say which providers are seeing patients. And we published this, and we have a lot of these data. We have them for every state, but you can get it on our website. Really, really interesting. We generated charts like this, where, for example, in these three states, Vermont, Wyoming, and Michigan, in all three of them, 71% of dentists were enrolled as Medicaid providers in their program here. Interestingly, when you go run the claims data to see, well, how many patients are those 71% of dentists seeing, you get really, really different results. So for example, if you go all the way to the bottom, you see that 29% of dentists in Michigan were not enrolled as a Medicaid provider. So that's the opposite of the 71. But if I go into that 71% that have enrolled, 15% of them actually saw 0 patients. So there is a, I don't know what you want to call it, ghost provider, people that enrolled and didn't see any patients. You go up to Vermont, it's very, very different. You have a very small number seeing 0 patients. In fact, in Vermont, if you go all the way to the right, you have about 1 out of 3 dentists in Vermont seeing a quote unquote high number of patients, 100 or more Medicaid patients. Go down to the bottom in Michigan, much, much smaller number, 10%. So the point here is we're really happy that we can get beyond this type of number, what providers are enrolled, because these 3 states had exactly the same percent of providers enrolled, 71, but a really, really different picture in terms of the intensity of that participation in Medicaid. You know, you have almost 1 out of 6 in Michigan seeing 0 patients. And you go up to Vermont, you have a significant share seeing a high caseload. Anyway, that's kind of where we started. So I want to talk about what this paper we're going to talk about contributes. So what did we do? We set out to measure which dentists participate most intensively as Medicaid and CHIP providers. We relied on detailed Medicaid and CHIPS claims data. This is really important. This is the universe. This is not a sample. This is literally the stock of all claims in dentistry and Medicaid and CHIP departments. What's really cool is we merge these data at the individual dentist level, and we're able to basically link an individual dentist to the Medicaid patient load they have. And the nice thing is, because of the data we house here at HPI, we know the dentist's age, gender, race and ethnicity, what type of practice they are, their address, and a whole sort of issues. We know what dental school they went to, things like that. Moreover, because we have geographic data on the dentist practice location, we're able to merge in census data on things like community characteristic. So for example, in the zip code where the dentist is located, what's the percent of patients that are white, black, Asian, non-white, etc.? You'll see that in a second. And just as a caveat here, while we have the data for all states housed in HPI in terms of the Medicaid claims or access to it more properly, we did not include all states in this paper. We excluded, I believe, 7 due to missing variables. So 43 states included in this analysis. So here's the game plan. I'm going to turn it over to Kamyar Nassh, who's going to walk you through some of the key findings. And we're not going to go into big detail here. The paper's online. It was available via the registration. It's pretty prominent on HPI's website, ada.org/HPI. You can get all the details there. Trust us, Kamyar is an extremely disciplined health economist. You can get all the methods you want there. But Kamyar's worked in HPI. He's going to walk you through the key findings. Then we're going to open it up to our panel today. We're joined by 3 panelists. Chelsea Fosse, who's from the HPI team as well, who's led a lot of our Medicaid work in the last couple of years. And then we're very pleased to have Romesh Nalliah and Bianca Frogner to join us. Romesh is at the University of Michigan School of Dentistry. He's the Associate Dean there for Patient Services. And he's also an Associate Editor of JDE, the Journal of Dental Education. And Bianca is coming to us from the University of Washington. She works on a broad set of health workforce issues, dentistry, and many, many other occupations in healthcare. So it'd be great to kind of get her insights as well. Again, for you all in the audience, keep the Q&A coming. Use the chat function for any sort of technical issues. With that, I'm going to turn it over to you, Kamyar. Take it away.
Thank you, Marko. So I'm going to be talking to you through the results of our findings today. So as Marko mentioned, we use data from TMSIS, and as many of you are aware, this is a fairly new data resource for health services researchers, health economists. And basically, each state is required to provide Medicaid and CHIP claims to CMS. And as of 2016, every state has submitted claims to TMSIS. So what's really cool about this data set is that it has for one, it has dental claims, and we're able to extract the dental claims using the CDT code. And we did this for kids age 0 to 20. Also, this data set has a linkable provider MPI field, which enables us to merge back to our provider database. So for each dentist in TMSS, we enumerate the number of unique patients a dentist sees in calendar year 2017. And we merge this back to what we call our office database, our provider database, which is basically the denominator. So we link by MPI, and our office database maps dentists into specific office locations, whether they're part of a DSO or FQHC. It has county zip codes, which we can link to census data. And it also contains dentist demographics, such as age, race, gender, and specialty. We limited the analysis to only general practitioners and pediatric dentists, since these dentists are more likely to treat children. Next slide, please. So what are we trying to do here in our methodology? So we're basically trying to estimate the expected number of patients a dentist sees, Medicaid patients the dentist sees in a given year. So dentists, when they participate, they have to make some decisions. A, whether to participate in Medicaid or CHIP, and then conditional on them participating, what's the intensity of their participation? So essentially, we estimated a hurdle model where this hurdle model enables us to disentangle the participation decision and the intensity decision, or how much to participate, conditional on participation. So we control for age, gender, race, specialty. We merge in various census variables such as poverty rate, household income, the racial ethnic mix of the local area where a dentist provides services. Specifically, we merge in whether a dentist works in a majority non-white zip code. We merge in measures of dentist supply. And to control for differences across states, we include state fixed effects. So next slide. So overall, in our data, roughly 33% of dentists see at least one Medicaid patient in a given year. This is lower than the earlier slide that Mark showed you based on our ICANN data, which was about 43%. So this makes sense. So 67% of dentists in our sample do not have 0 patients. About 5% see 1 to 9 patients, 11% have 10 to 100 patients, and about 20, almost about 18% have over 100 patients, Medicaid patients in a given year. So what we're trying to estimate here is the predicted expected number of Medicaid patients treated. And we look at various independent variables. We look at dentists per population, median household income. And so here is just an overview of kind of like what we're estimating here. And I'm going to show you like some of the key variables in our analysis, but basically will show up some key interesting variables. So in areas where the dentist supply is lower, meaning say 30 dentists per 100,000 population, a dentist is expected expected number of Medicaid patients a dentist sees is about 342. In areas of high dentist supply, say 120 dentists per 100,000 people, a dentist is expected to see 140 Medicaid patients in a given year. So by median household income. So we looked at areas of high and low median household income. So in poor areas, say in counties where median household income was $30,000, the expected number of patients the dentist sees is about 372. In higher income areas, say in areas where median household income is at $120,000, the expected number of patients a dentist sees is 114. So essentially in poor areas, we expect a dentist to see more Medicaid patients. So practice size, this is an important variable. So we're trying to get at the structure of dental practice and how this affects participation and intensity of participation in Medicaid. So in larger practices where large practice sizes where there's 11 or more dentists are expected to see a higher number of Medicaid patients compared to compared to practices where there's only 1 or 2 dentists. So the marginal effect of working in a larger practice leads one to have a higher intensity of participation in Medicaid. And we also looked at race and ethnicity. So in minority dentists, Hispanic, Black, and Asian dentists are expected to see a higher number of Medicaid patients in a given year. White dentists have a lower intensity of participation in Medicaid in a given year compared to minoritized dentists.
Hey, Kamyar, it's Marko here. I just want to jump in for the audience. What Kamyar is showing you is the regression adjusted results, so to speak. So this is after adjusting for age and gender and practice type, etc., all the other variables. You still see a pretty important effect by the race of the dentist. And you see a clear effect. It's kind of white and non-white. Those differences between Hispanic, Black, and Asian, again, I don't know if they're statistical, Kamyar, but they're not that meaningful anyway, the numbers. But there's a big difference between white dentists, all else equal, and non-white dentists in terms of their participation in Medicaid. Sorry to jump in, Kamyar, but just so the audience knows, these are the adjusted results.
Yes, these are all adjusted. So when we look at dentists locating in majority non-white zip codes, where there's a minority population, it is expected that dentists sees more Medicaid patients in a given year compared to dentists that locate in majority white zip codes. So it's not only the race of the dentist that has an impact on how many patients, Medicaid patients, a dentist sees in a given year, but also their own race too. So where you locate and who you are really determines the number of Medicaid patients you're expected to see.
And again, Kamyar, why this is such a novel analysis that we did and that you did is, again, you could think of this as if white dentists are just locating in white high-income areas where there simply are no Medicaid patients, it could be that just the sorting geographically is what's driving this result. What Kamyar is showing here is that's not the case, is that even when you adjust for the characteristics of the neighborhood, there's still an effect. And Kamyar, this is that chart that you'll get to in a second, actually, that pulls that all together. Okay, back to you.
So yes, when a dentist locates in a rural area, controlling for other factors, a dentist is expected to see a higher number of Medicaid patients compared to non-rural dentists. So this is an interesting chart that I want to kind of walk you through for a couple minutes here. So let's think of 5 dentists: a Hispanic dentist, a Black dentist, a white dentist, or a dentist of another race, right? And let's put them in a majority non-white zip code, right? So essentially we're stratifying by race here. So when a dentist locates in a majority non-white zip code, the intensity of their participation goes up for all races. But notice that when white dentists locate in a majority non-white zip code, they're only expected to see 97 more patients on average. Whereas if, say, a Black dentist locates in a majority non-white zip code, they're expected to see 144 more Medicaid patients in a given year. So basically there's a bigger minority dentists react differently and participate more intensely when they locate in majority non-white zip codes compared to white dentists. Yes, all dentists of all races increase the intensity of their participation in Medicaid, but minority dentists do so more. I hope that makes sense. But you can see the error bars, they don't overlap between white dentists and the Hispanic, Asian, and Black dentists. So what are the key findings in our analysis? So high volume Medicaid patients are less likely to be white. They're more likely to be located in a non-white. High volume Medicaid patients are less likely to be white, more likely to locate in a non-white, rural, or high poverty area and work in a large group practice and be affiliated with an FQHC. This is consistent with previous research. So there was a study done by Spivak in Health Affairs, which looked at, on the medical side, for looking at physicians, looking at the percentage of Medicaid revenue a provider has. And what they found was similar to what we found, that dentists in rural areas, high poverty areas, physicians in those areas are more likely to participate in Medicaid. Likewise, we have similar findings here. The racial and ethnic differences in Medicaid participation are not accounted for simply by where dentists locate. Controlling for the demographic makeup of the neighborhood is important. So white dentists are still less likely to participate in Medicaid than non-white dentists. Practice modality matters. So dentists that work in practices in larger group practices are more likely to participate in Medicaid. So what should policymakers keep in mind going forward is they need to promote the growth within the segments of the dentist workforce that treat more Medicaid patients, i.e. dentists who are Black, Hispanic, or Asian. Those that locate in rural areas. By targeting these dentists, they can create a more robust dental care safety net for low-income populations. So, ready for the Q&A.
Okay, great. Thank you, Kamyar. So, panel, let's all come back here. Let's turn our videos on. There we go. Thank you, Kamyar, for walking us through the highlights. Again, what's really novel about this paper, and we said this, there are a few things, but this really disciplined treatment of race and the interaction of the provider and the population, I was excited about that. I hadn't seen that done in dentistry. There's lots of descriptive work done about differences by age, gender, race, and how dentists behave. But I think we've done a very detailed and disciplined way to tease those out. So I love what you said, Kamyar. Magically drop dentists of different races in the same neighborhood. What the research shows is they have a very different response in terms of taking on Medicaid patients. So there's Romesh, there's Bianca, there's Chelsea, welcome. I guess, again, to the audience, keep the Q&A coming. Sylvia and Adriana are working behind the scenes for that. Let me just start with a quick kind of what surprised you or maybe what didn't. And maybe let me start with you, Romesh, and welcome again. And then let's go Bianca and Chelsea.
Thank you, Marko. And I'll just say it's a real privilege to be in this group with Chelsea and Kamyar and all the great work that you do. And great to see Bianca as well. You know, on some level, the results were somewhat disturbing, weren't they? Like, you know, I guess I think about, so firstly, I think the paper is beautifully done, and there's so much more time needed to unpack the way that, you know, the different elements of things that you've found. But like, I sort of come back to, you know, race is not a real thing. Like race is a social construct, right? But you have found so many differences based on race, and it just speaks to, you know, I guess the history of this country and the way that we've treated different people groups and things of that nature. And so, like, I guess I'm still processing it, but I'm just like thinking about what an impact this social construct has had on the way people practice, the way people seek care. It's quite astonishing.
Great. I want to dig into that, but that's our next round of questions. Bianca, surprising something or something not surprising?
Well, thank you for, again, having me as being part of this panel and being able to comment on this work. I mean, it really should be stressed how unique it is to have this opportunity to connect the claims data with survey data on the characteristics of dentists, because that process is so rare for us to be able to do across the health workforce. So that by itself was just great work that you all have done around that. But I think if anything, this study certainly seems to raise more questions that may answer, but it certainly gives a good solid starting point. And I think the biggest concern is this idea that you have white dentists practicing in somewhat diverse neighborhoods, and that there's a significant difference in terms of their, patient load, Medicaid patient load. And one has to ask a little bit why that's happening, how that's happening, what kind of sorting is happening there. And there's just so few other studies. I don't even know if I can think of a study that really looks at it in this kind of a way. So we have seen other studies that look at concordance of providers with racial concordance or ethnic concordance between the patient and the provider, and then ultimately what does that mean for the quality of care. But what you're looking at is a little different, which is actually what are the patients that they're taking on. Now, I understand this is just children, so there's certainly there's questions that might come up about adults that may be seen and what's the full panel that's being seen. However, it's a great starting point, and that is a concern that we should be considering, as the diversity of the children being seen by white dentists in some of these neighborhoods.
Okay, great points both you raised. Chelsea.
Yeah, so I think a couple new things our team has learned really goes back to the DSO effect and the practice size effect. So in the past, when we had looked at this, we thought at the time that dentists who were affiliated with DSOs were much more likely than those not in DSOs to be Medicaid providers. And we know that some DSOs, that's really part of their core mission, some not so much. But what we found this time around was DSO affiliation really has a negative effect on Medicaid participation. And what seems to, be playing into this is more so.
I would say neutral effect. I want to say negative effect.
Okay,
I would say neutral. Yeah.
Thanks, Kamyar.
No.
But the practice size is really a huge part here. So, those who are in group settings or more than 2 dentists, we're seeing that they have much more participation or more intense participation than those, in practice with 1 or 2. Another, if I can say one other quick.
You can, okay. But let me, because I want to clarify, because we didn't go into detail on this in the presentation. So there was a variable for both practice size, how many dentists are in the practice, as well as whether or not you're in a DSO type model. And what came out as significant was the practice size. Now, look, those are confounded and it's not perfect, right? But I really like, Chelsea, that you brought this in, because I don't want to gloss over this. It looks like the practice size is really what's driving this. It's not necessarily DSO and, corporate dentistry, et cetera. And I use that as quotes for those of you listening in. So I think that's important. Now, I want to ask Bianca later, medicine obviously has gone through consolidation, and that, is that a good thing? This is suggesting size is a good thing for taking on more Medicaid patients, but we'll get to that later. Back to Chelsea, your second point.
Yeah, second point. So we also learned a lot on the race piece too, because when we had looked at this before, and we were only looking at Medicaid enrollment, we did not see that Asian American dentists were participating with that level of intensity in Medicaid. Now there's a totally different story. We're seeing that Asian American dentists are participating even more intensely than the other non-white dentist groups. So I think it's really important. That's been a really good learning lesson for us too with this new data.
Yes, and look, I want to all the HPI critics who always every year send us information about why we shouldn't be measuring participation and why it's flawed. We always said the same things you all said, but we're very transparent. This is all that's out there. Now I want to hear the kudos. I want to get emails saying, awesome, you guys did 2 years of legwork to try to get TMSIS data. Awesome, you're measuring patient counts and not just whether you enrolled as a provider. Let's be fair, folks. I'm not going to name names here, but I expect a full inbox tomorrow morning, all right? Okay, let's do something else. I want to ask Romesh, well, actually, let's get into Romesh's underlying question. And look, we love having debates. This could get uncomfortable. That's what research is about. We're trying to be guided by the evidence and ask the right questions. But Romesh, let's dig into this. What might race be measuring? Because it is a social construct and it's a variable that might be capturing a ton of things. So I guess I'm asking, what might be correlated with white and non-white that might be driving some of these results? And basically race is capturing it, but it's something else. I mean, let me start with you, Romesh. And what I love is you sit at the center, right? Like you're training the next generation and you're seeing big changes in the demographics of dental students, right? More are non-white. And again, that varies by school, but I don't know. Tell me what might be different here about white dentists that we would have liked to have measured.
Yeah, I mean, just as you and Chelsea were alluding to, this participation rate as a measurement should not, dentists should not feel like this reflects on them because there's so many different factors that go into participation rate. One of the things is how different Medicaid is from state to state. I'm here in Michigan. Okay. I'm here in Michigan, and in fact, I learned this from a paper from Kamyar, you and I think Marko too, on our reimbursement rate is 20% of commercial insurances in this country. We're one of the, I think we're second or third worst in this country. So it's real tough for dentists to, find a workable solution there for Medicaid with such low reimbursement rates in this state. Currently, there's a discussion, there's a proposal to dramatically expand Medicaid in the state of Michigan. But that's another huge variable, I think, is Medicaid is so different from state to state. I mean, I moved here from Massachusetts, and it's completely different in Massachusetts. It's one of the nation's best. And, adult dental Medicaid here is, it's not as well funded, shall we say. I don't want to say that it's bad, because also this depends on state budgets, right? So it's difficult. And frankly speaking, we have positioned our profession in a way that it is easy to take it off the table. Like when there are budgetary constraints, we are not there married to medicine, and we're not, in many ways, in fact, this paper alludes to that. It's a luxury, isn't it? 67% of dentists, I think you found, take no Medicaid, right? And 82% take, no or fewer than 100. So then think about the patient with Medicaid. Where do they get access to care? Like, it's a luxury item at this point, right? And so unfortunately, our profession has positioned ourselves in this way as a luxury item. So then, yeah, when there are budgetary constraints, you lose out, unfortunately. So we've got to reposition ourselves. So, okay. Yeah, I think that's hard to answer, Mark. There's so many different factors, but I wouldn't want dentists to be offended by this participation rate, because I would want them from your paper to understand that there's many factors that lead to actual participation. That's a proxy for the variety of other things that could be measured.
All good. Kamyar, clarify though, we include fixed effects for state.
Yes,
so,
we do.
In a sense, Romesh, we're adjusting that Massachusetts is different than Michigan and all that. So some of that is accounted for in the analysis, but I get your point more broadly about the complexity of the decision. I think what we come back to again is that, granted, all right, Medicaid pays low, and it's not like medicine where the huge patient base is covered by Medicaid or Medicare, right? But yet we still have these statistical differences according to practice type and race, right? So, Kamyar, very quickly, because
even if you exclude those state fixed effects, our results were similar for the most part.
Okay, so it can't be just that some states have very low, and that tends to be where the white dentists are or the non-group practice dentists are. But anyway, great points, Romesh. Bianca, do you want to chime in on that? I want to ask, like, what could race be measuring? Because I'm with you. I think it's more to me of, I love what you said, Bianca. It raises more questions. Like, what is it we really want to measure here that maybe race is proxying for, right?
Yeah, I mean, it certainly speaks to some issues around access. I mean, there is this question of this low participation rate in the Medicaid program generally by white dentists compared to non-white dentists, kind of asks this question of, since there's so many more white dentists in America, so where are our minoritized populations potentially getting their care from if they can't get immediate access to as many of the dentists that are out there? And I would actually think that good qualitative work is really warranted here to better unpack whether this is a purposeful decision that's being done by practices to take on certain insurance programs, and how reimbursement is translating to their bottom lines. Because while we know that Medicaid does reimburse at a lower rate than private health insurance, what part of that puzzle we're also missing though is volume of services and how that might be all adding up to total revenue. So at the end of the day, how does taking on Medicaid patients kind of factor into practices' decisions about the patients that they try to attract that ultimately hits their bottom line? And I don't want to spoil some future study results that I am working on with you all around looking at the wage effects. But what my big concern is how the taking on of Medicaid patients might be potentially hurting our minoritized dentist population in terms of their wages that they may receive. And then therefore it may become discouraging for minoritized dentists to enter the profession if they potentially may see lower wages. And that is a concern that I have when I see these kinds of data, as it
That's a great point, right? So in a sense, is there like an economic penalty, right? Yeah. So to speak, that non-white dentists are kind of bearing. Now look, again, I mean, I want to, maybe Chelsea, I'm going to ask you a different question, and then Adriana, get ready. I see over 70 questions coming in, so hopefully you had your hands full. You know, let's, do we really care about any of this? So let's, we've said it's new research, it's novel. Does it matter who participates in Medicaid as a provider or not? Do we care whether who cares that large group practices are more likely to do this versus not? Any thoughts there? And I know Bianca, you too, you've worked on stuff. We know outcomes are better. We know there is a racial concordance thing, right? In terms of patient and provider. But again, I don't know that literature so well. Chelsea, any thoughts? At the end of the day, policy-wise, does these results matter?
I think absolutely. And this group might be a biased one. But if we don't, somebody else will. And somebody else will figure out how to provide oral health care services if dentistry doesn't step up to the plate, or if dentists don't step up to the plate. Yeah, so I think we have to care. And I think that gets to another point, going back to your other question on what is it behind race? And I think while this would need more qualitative work for sure, part of this is there are probably some cultural differences in what's driving these different subgroups of dentists to the profession. And to go into dental school, you mean? Right, to go into dental school. So going way back to the pre-career days, and what are those driving factors for entering the profession? Is it more about that? Is it more that servant attitude versus the entrepreneurial aspect of dentistry? And is that what we're seeing with non-white dentists? Do we know anything about that? I mean, Romesh, I'll ask you, but Bianca too. In terms of motivations for going into dental school, is there research? You're at a school, Romesh. I mean, what Chelsea said, is there systemic different motivations for going into the profession based on your circumstance, where you grew up, your race, etc.?
I'm not aware of research that breaks that down by race, but that's a terrific point by Chelsea. I mean, everyone knows this, it's a seeking autonomy, wanting to serve people, wanting to run your own business, but I've never seen that broken down by race. That could be very fascinating.
Okay. Bianca, anything from the broader literature maybe we could bring in?
Yeah, I would say that what we have seen is that we have better success of, say, having primary care providers work in rural areas if they come from rural communities themselves. And so that's kind of speaks to this idea that maybe some primary care doctors that come from rural areas have the interest in helping their own communities because they've been raised in those communities. They've seen the lack of access. So therefore they want to go through, they want to get the education and training to be able to go back to their communities to help. And this isn't just physicians. It certainly has been the case also for nurse practitioners, physician assistants, and others. So I do believe that there is some kind of service-minded model that kind of might motivate students to come into these programs and then ultimately go back to serve their own communities. And we should certainly look at that and make sure that there aren't some other barriers that prevent these providers from taking on or having the full practice that they want to see. Now, I do want to just add that the other piece of the equation that we don't fully have here are who are the other employees in the dentist practice who also provide care, including the diversity of dental hygienists and the dental assistants that may be practicing in the facility, because I do think it's important to figure out whether, for example, white dentists who work in more minoritized neighborhoods, are they employing more minoritized dental hygienists or dental assistants? Because they do play a critical role in the care being provided. And so we just want to make sure that we think about the whole care team and the diversity of that care team and what that might speak to also patient preferences in the neighborhood and how they may be looking at those practices and who they're employing and who they're facing immediately upon entering the practice. And thinking about that whole system of care for as
great insight. Yeah, while we bring Adriana in now, let me just reiterate, like you're all saying it, right? This work certainly advances our knowledge in this area, but it's not like it's the definitive work. We have a lot more questions to answer. I really like what you said, right? And that's what good research does. Yeah, it gives you some insights and then it says, what's the next question we got to ask? And that's kind of, I love talking about this with all of you, but we have 84 questions. Adriana, you've obviously had your hands full. So welcome. This is Adriana Menezes from the team. Take it away. You've been sorting through. So
yeah, thank you so much. Thank you so much. Good morning, good afternoon to everyone. I don't know if we'll be able to cover all of them, but we'll do our best to cover at least like the broad questions. I'd like to start by backing up just for a minute with a few clarifications about the data, the results that were presented. There are several attendees who asked about what we meant by expected. Linda said, you keep saying expected, does that mean the ADA expects it? Or are you saying that if you are a certain ethnic background, the average number of patients you see is what is seen on the chart? And Donald said, average is meaning of expected is okay, but is there a way to determine if the social construct is more influential on the population selecting to choose dentists, or if dentist characteristics and practices are more influential? And if they do, how much?
I want to go quick on this. Kamyar, you correct me if I'm wrong. Expected, you should think of as predicted. Once you do the modeling and it's okay. You're muted, Kamyar, but I don't want a technical explanation. So maybe that's
I would
a sign.
say expected is like the average predicted what you would.
Perfect.
Yeah.
Okay. So it's predicted. It's nothing normative. It's when you adjust for all the things in the modeling, this is what the predicted number is. So, and then on the second one, it's great. We don't know. To Don's question, we don't know that. Like I've said, it's a hypothesis to test, but what I think at least we've contributed is to account for the neighborhood characteristics. Now, what's driving what is we don't know. Yeah? So let's go on.
Yeah, one other quick question about the data. It is 2017 data, and why is it 2017?
At the time, so we have our office database. At the time,
that was the most recent TMSIS data when we started. That's it.
Yeah, the most recent office database when we started matched up with TMSIS. Yeah.
So we plan to repeat this, at least descriptive, right, as we get newer data. But again, there's a lag with the claims data. So.
And I think one last question about the data presented. Just to be clear, this is just for children, not for all Medicaid patients, right? That's a question from Beth.
Correct.
Yes.
Okay.
Correct.
Okay, thank you. So speaking of
And
Beth,
again, that's a nicely loaded question in a good way, because we would love to do this, but the problem is it's a patchwork of benefits, right? So many states don't have adult dental, so there isn't really a program. They're not comparable. At least with children, you roughly have the same coverage package, yeah, across states. But it's a good one, Beth. It's a good question. Maybe we'll pick off state by state, like some states like Washington and others that do have extensive coverage. Am I saying it, Chelsea, right? I pick Washington, correct? Okay, good. Maybe to do some state by state ones like that one off. It's a good question. Yeah. Okay, let's get into some meatier ones.
okay, so I'm going to go back to, I believe it was the first question submitted by Beth in the beginning of this the webinar, and she was asking about the goals providers slide, and she asked why 100 patients is considered a high case load.
Arbitrary.
Okay.
If I can just add, in most medical research on this issue, they use 150 patients as the cutoff. So just for comparison.
And somewhat related, what are the reasons a provider would enroll in Medicaid and not actually see patients? Is there some business benefit to doing that?
Maybe Chelsea, you want to take this?
Yeah, great question. Don't have a good answer for it. We're trying to explore that too, at this point, kind of qualitatively. I will say there's at least one state, and this wouldn't be reflected based on the timing of implementation in this data, but Massachusetts now has, when a dentist is submitting their application for initial licensure or renewal, they are required to credential with Medicaid, even if it's as a non-billing provider. So I'm really excited to see what we see with Massachusetts when we run this data again to see if that's had any impact. I think that's an awesome policy step, and we'll see if it has any impact, but don't have a great solid answer for that quite yet.
Other reasons too, your practice may enroll you, and you may not know, they just may enroll all their providers if they're a large group, maybe. It could also be Colorado a few years ago had an initiative to really like enroll a Drive for 5 or something like that, trying to kind of promote every dentist taking 5 patients. It did not work. A bunch of people enrolled and saw 0 patients. So, and again, not good or bad, it's just the result of the research. So there's a few reasons that Chelsea and I shared. Yeah. Pick something more controversial.
I can jump. So there are a lot of questions. I just want to make sure that I acknowledge there are a lot of questions about the data, what data is available, how it's available, a lot of TIPSIS data. So that's exactly what I was going to say. But I would like to read one of the questions related to that was from William. And he said, were you able to obtain any metrics from the MCOs in states where Medicaid has been contracted out to MCOs?
That's a good question. We didn't split this out by MCO state and fee-for-service state.
So the question is, yes, those states are included, but they're not analyzed separately.
Well, I noticed some of the states we excluded, like Indiana, maybe another one, those are managed care dental states as of 2017. So maybe some of them didn't even like provide their MPI number too. That could be. But even we included state fixed effects in our analysis. Those that in theory should swallow some of that policy variation up.
By the way, we had a paper published recently, again, led by Kamyar, that looked at managed care versus non-managed care states. And the outcome, Kamyar, was simply the rate of visits, right?
Utilization went down.
Utilization. That's on our website too, but it's another topic. Adriana, back to you.
All right, so if you want controversy, I'm going to jump into the questions about race and ethnicity.
Okay.
There are a lot of them. So, and apologies, I'm just going to read them at random. So,
read a few and then we'll react.
Okay, so Kendra asks, why is the focus on promoting growth with non-white providers versus discovering why white providers are not participating in the same levels?
Okay.
Another one at random. For the participation of white dentists practicing in non-white areas, their participation in Medicaid is lower than non-white dentists. But does this take into consideration that non-white Medicaid patients would likely prefer a non-white dentist? Are you assuming all patients choose their dentist independent of race? And I think that's been touched when Bianca was talking earlier. I'll read one more. Frank, as recent publications point out, the lower income of Black dentists compared to white dentists. Any comments about that related to this great study? Really nice, well done. So here's your compliment from Frank, Marko.
Hey, okay, we'll take it. Yeah. And thank you for joining, Frank. You've done great work in this area as well. And I love the question, the last one. So Bianca touched on this, right? Does the lower income of Black dentists correlate with some of what we found, that they tend to be the highest in terms of Medicaid provider or Medicaid patient load? Again, not to steal Bianca and Kamyar and my thunder, but we have a paper under review right now. We're just revising it. There is still an independent race effect after controlling for the share of your patients that are Medicaid. So while that we think explains some of it, it doesn't explain all of that wage gap. Really cool paper coming. The first one from Kendra, great question. I mean, I'll jump in and then panel react. We're not promoting anything here, just to be clear. These are the results and these are the policy implications. Now, what do you do from this? Should you try to recruit many more non-white dentists? Should you try to figure out why white dentists are doing what they're doing? Great questions, Kendra. So does anybody want to hypothesize? She asked basically, like, do we know anything more about the behavior of white dentists and why it's different? I know you touched on this, all three of you.
I read, there was in some of the concordance literature where I guess they were trying to say that encourage minority providers to treat minority patients, because then your outcomes will be better, whether those like be birth outcomes or cardiac health outcomes. Am I correct? I was some papers.
There is, right? So there's literature in medicine, but let me get right to the point. Let me be controversial, right? Is it up to the non-white providers to solve the non-white access issues, right? Is that our vision? You know what I mean? I'm asking it as a question, Romesh.
It's absolutely not, and I totally agree.
Not,
with Kendra.
right?
I totally agree with Kendra. You know, promoting Black and Asian and Hispanic dentists to go into these areas is a band-aid. What is really needed is we really need to become the United States of America, right? And we need to take care of all of our communities in need. You know, why are people in these situations? Like, why are, you know, there are you know, Black Americans are, you know, more likely to be on Medicaid, less likely to you know, graduate high school, less likely to enter dental school. It's because of racism. It's because of 300 years of structural racism in our education system, in our health system. So, you know, this is a national crisis. We don't need, so, you know, we can't ask one community to go back to their community. This is a national crisis. I mean, if there's a fire, if there's a wildfire in California, we don't say, well, all the white firefighters go to the white sub. It's a national crisis.
Yeah, right, okay.
It's all hands on deck, right? And it doesn't start at dental school. Honestly, the ADA and ADIA must join forces to start at elementary school, right? Because by the time, you know, when we get to dental school and we're fighting over these highly, you know, successful candidates, there's many people that have missed out because of racism. You know, our standardized tests are sexist and racist. We still use them, right? There's so much work that has to be done to unpack this that Kendra, I'm totally on your page.
Great response, great insights. Bianca, Chelsea, jump in too.
I just want to add that the literature on racial and ethnic concordance between patients and providers is kind of pointing more to the ability of a provider who comes from a similar background as the patient having the ability to recognize or understand the patient's life circumstances, including, you know, their patients' encounter with racism in society, to then address and advocate more for patients. And so that's partly why we want to try to have a provider population that looks more similar to our patient population, is because there's this cultural understanding that the providers are having when one looks like you just understand each other, and you know the culture from which they're from. They know the food that they're eating. They know the life that they're living, the struggles that they're having, that then providers can tailor care a little bit better and hear their patients in a way that others may not. Now, all that being said, we currently have a fairly non-diverse dental workforce, and we don't have enough time just to wait for a diverse dentist workforce to then solve our problems. So I think the issue then goes more towards what can we do to improve cultural competency among our dental providers so that they can feel comfortable caring for patients that may not look like them, because it is not the patient's responsibility really to get the dentist to understand them. They need providers who are getting the training so that they feel comfortable taking on these patients, and that we need to figure out why white dentists may not be taking on more of these patients. Is there a bias here, an explicit bias that's taking place, or is it more implicit? Do they feel uncomfortable about caring for patients? What is it that we need to provide those dentists to feel more comfortable taking on
or is it
patients?
Sorry to cut you off, Bianca, or is it something completely else? Like literally my aunt and uncle are dentists and I'm going into their practice. I'm kind of like, maybe there's more of that among white dental students than there is among Black and Asian. And I don't know,
well,
right?
Not only that, it could just be purely financial. It could just be purely financial decisions that are related to this, that again, that we have a disproportionate number of Black and Hispanic patients who are on Medicaid, and so therefore there's this sorting. I mean, that's what you're starting to dig into with this paper, but there's that missing piece of the private health insurance part that we just don't see that full picture yet, but it's coming, I know.
Chelsea, hang tight. I'll skip over just in the interest because I see we're over 100 questions here. So I don't know, one more, Adriana, let's see how.
All right. Yeah, and there's so much great commentary in response to this dialogue. It's not all questions. We really appreciate it, and we're going to read everything and take in consideration. So thank you so much. But let me just shift gears a little bit and touch on something that we haven't discussed yet, which is practice size and type in the results. So Paul asked, or he said, it looks like the data says that dentists in large practices are more likely to participate in Medicaid.
Yes,
but this is not true for DSOs. Is that correct? And how do you understand this, since DSOs tend to be the larger practices? And then another practice size question, it starts with, thank you, excellent work, thank you. And then a comment, what do you see as large group more likely reflects higher turnover in Medicaid offices and providers, and not removed, not de-enrolled after leaving? I believe that was just a comment, not a question. So
okay, that's to be determined. I know a lot of people think that high staff turnover in large groups. We don't know that. I haven't seen research. But I don't know, Chelsea, why don't you start? Now, the DSO versus large group, again, we didn't want to make too much of this because they are somewhat confounding in measuring the same things. We had data on both. So the way we interpret this is, it looks like the group size is the true driver, not the fact that it's a DSO or not. Now we know that DSOs are larger. So put it this way, if you take a non-DSO practice and you double it or triple it in size, we would expect that now more of them take Medicaid. So put it that way. But Chelsea, why? Is this just like scale? Is it efficiency? Is it mission? What is it?
I think so. I mean, I think this is an economies of scale issue. I mean, I think when in practices that are seeing a lot of Medicaid patients, you obviously have a really good administrative and operational backbone. You need that just because of some of the administrative complexities that come into this and others. So I do think it's an economies of scale issue here.
Okay.
Spivak had a health affairs paper looking at physician practices, and they found that larger practices had higher percentage of Medicaid revenue.
Right. Okay.
Total revenue. Yeah. So they found very similar results to what we found. They looked at practice size and they found very similar findings to our findings, which is, reassuring. So
right, and that's a good point. Like
on the medical side, so like dentists and physicians are behaving similarly, it seems.
Yeah. We are right on time. We should have scheduled this for 90 minutes. As Adriana said, we're going to capture all the comments because the discussion online has been really lively and really helpful for us. But we will respect people's time. We have to close. I just want to thank Bianca and Romesh. It's been amazing having you from your different perspectives, your wisdom, your thoughtfulness, your insights. And if you know these folks, they're also super nice people. But just a pleasure to have you on the panel. We'll have you again. And again, thanks to Chelsea, Kamyar, Sylvia, and Adriana from our team here. So we're going to sign off. Again, look for the recording. And thanks to everyone big time for joining. Okay, have a nice day.